Leaving on your own terms is something that many seek. Joining me now, Dr. Ezekiel Emanuel, Chairman of Medical Ethics and Health Policy at the University of Pennsylvania and Senior Fellow at the Center for American Progress. Welcome, Dr. Emanuel.
Thank you for having me.
Well, you've been studying these issues for many years now, writing about them. What needs to happen for more older Americans to die on their own terms?
Well, first of all, I think we should clarify that we have had in the last 30 years, certainly since I've been working in the area, a pretty dramatic change in how we do care for patients at the end of life. When I was in medical school in the early 1980s and beginning to work on end-of-life care issues, more than 70% of patients with cancer died in the hospital. And we know that now it's less than 30% and probably less than 25%. So we've had a dramatic change. Certainly when I was starting out as an oncologist and a cancer doctor, we did not regularly use hospice care. Now it's become routine for more than half of patients with cancer to get hospice care at the end of life. And the third point I would make is that when I was training, again, to become a cancer doctor, we did not even have a training module on end-of-life care or communicating with patients about end-of-life care. And now,
but let me ask you though, even with
almost every cancer center in America has palliative care and end-of-life care issues as part of its training, but also part of its service offering. So there has been over 30 years a big change.
A big change.
That doesn't mean we're perfect.
I was going to say, even with the dramatic changes though, still put the problem for us in perspective. Would you still say that too many Americans die, first of all, without making their wishes known and without having their wishes carried out?
Yes, and I think many of us don't like to confront the fact that we are going to die and talk about it. You know, I happen to be an expert in it, so I've talked about it a lot with my family, and my children certainly know my wishes clearly. But a lot of us want to avoid that. We don't like to dwell on the fact that the end is going to come for us. We don't want to think about it, and so we put off having that discussion. And similarly for doctors.
I was going to say, yeah, let's talk about the role of doctors in all of this, because you said we are seeing more training in medical school, but is there still, and some surveys seem to bear this out, a tendency to treat and to treat aggressively?
Yes, and I think that's true, and I think we need to put that into perspective. Certainly when you care for a dying patient, the hardest conversation you have is to go into a room and tell a patient, well, you know, we tried this chemotherapy, it's not working, and your cancer is going to lead to your death. That is an enormously difficult conversation. It's emotionally draining, it takes a lot of time, and it's typically not reimbursed well, and you may generate family conflict. So it's a conversation that's hard to have, and you know, naturally I think doctors avoid it. I think the next big issue is that we have to change how doctors, we have to improve how doctors learn about communication, specifically about end of life, because it's not just that. It's not only doctors who need to do it better, nurses need to do it better.
You want to see better coordination. That's one of the things you've been writing about. Yeah.
Correct. And I think making it much more seamless between the hospital, outpatient, and keeping patients at home would help. I also think that we need to understand that the finances here do sway things. Doctors are paid to give chemotherapy. They're not paid so much for hospice. I think that probably has to be changed. And I think also having this conversation, planning about end-of-life care is something, again, that's hard to do, and we need to recognize that it takes a lot of time.
Right,
and so we need to compensate doctors.
Let's talk about cost for a moment, because one of the things you've written is that the most important contributor to the high cost of U.S. health care is overutilization. So
I don't know about the most important. It's certainly an important contributor, and we know, as the Dartmouth study has reconfirmed, I mean, it's something we've known that.
Clarify that, how you're feeling on it. Is it one of the most important? Please clarify that. Perhaps you were misquoted by saying it was the most important, but clarify that for me. Mm-hmm.
There are multiple factors that lead to high costs in America. Certainly overutilization of services is one of them. And in the cancer field, I generally think we overutilize expensive treatments. We tend to overutilize what we call third, fourth, fifth line chemotherapies. That's after the main chemotherapies aren't working, trying something else. I think we overutilize that. We tend to give radiation in a way that's more expensive than less expensive. So I think there are many things we could do in the care of cancer patients, especially terminally ill cancer patients, that would save money and probably improve quality of life.
Let's talk about how we have this conversation as a country, because you know what happened during the Affordable Care Act, talk about death panels.
Boy, do I know.
Okay, and you were personally
I'm Dr. Death, yes.
Right, accused of that. All right, so how do we have a rational conversation about these issues?
Well, all the polling shows that the American public thinks that that's a conversation that should happen in the family and between the family and the doctor. The government should get out of it. But the government can facilitate it occurring by reimbursing for that conversation, not penalizing doctors for having it. And I think the other thing that can happen is that medical schools, hospitals can take responsibility for ensuring that all their staff, doctors and nurses, are trained in having a conversation about end-of-life care. That's not something which has happened, and I think that is something that should be required.
What do you see as legitimate concerns about rationing?
Well, I don't think that this is an issue about rationing. I think this is an issue about how to care for patients and how to make their last months much better for them, and also how to understand their wishes. Remember, a lot of this is not, I don't think it's about rationing, it's about actually understanding and eliciting what patients' wishes are and putting them into place. And it's too easy, again, for doctors and patients to hide behind, we'll try one more chemotherapy, we'll try one more procedure, when we know that those things have a very low, if no chance of really succeeding.
Well, thank you so much for joining us today, Dr. Ezekiel Emanuel with the University of Pennsylvania. We appreciate it.
Thank you.